Live from Boston, my name is Emilio Madrigal. Today is December 8th, 2020, and it's very cold in Boston today, actually. I am joined remotely by my good friend and colleague, Rifat Manan, who is in Philadelphia at the University of Pennsylvania. Today, we're very happy to welcome again Dr. Carlos Parra-Harran, who's an associate professor of pathology at Brigham and Women's Hospital, and he will be delivering the ninth lecture in the Pathcast GYN OB Pathology lecture series. The title of his talk is Squamous Lesions of the Cervix and Their Differential Diagnosis. As always, you can post questions and comments, and we'll make sure to pass those along to Dr. Parra-Harran and at the end of the lecture, and he'll be more than happy to answer those questions and respond to the comments. So with that short introduction, I'll turn the microphone over.
Thank you, Emilio, and thank you, Rifat, for giving me the space and the opportunity again to speak to a larger audience today on the topic of squamous lesions of the cervix. To our audiences that have been waiting for us to start, thank you very much for your patience. And as Emilio said, I'll try to answer your questions at the end. I have no conflicts of interest to disclose. We're going to cover the more frequent squamous intraepithelial lesions and their differential diagnosis, and touch on the diagnosis of stromal invasion in the setting of squamous cell neoplasia in the uterine cervix. Hopefully by now, we are all familiar with the lower anogenital squamous terminology for HPV-associated lesions in the cervix, which recommends a two-tier classification of low versus high-grade lesions that correlates with the previous terminology that we had for different anatomic sites in the lower anogenital tract that followed the intraepithelial neoplasia nomenclature. This intraepithelial neoplasia nomenclature is still relevant in certain scenarios, which we're going to discuss today. Low-grade and squamous intraepithelial lesions are relatively frequent, depending on the study and the population that you look at. They're prevalent in reproductive age women, usually peak around the third decade. We consider them low-grade because most lesions regress within 1 year and completely resolve. A smaller percentage, about 10–15%, will persist after 1 year of diagnosis. And according to the literature, between 7 and 13% will have a diagnosis of HSIL, or will quote unquote progress to HSIL at the time of follow-up. Now, is up for debate whether that represents true progression or undersampling of a high-grade area at the type of cytology or colposcopic biopsy sampling, or a misdiagnosis, which could happen. The features of a low-grade squamous intraepithelial lesion are basically cytologic in a squamous cell population that retains squamous maturation. So we are going to see a well-organized and uniform basal layer. And as the squamous cell population matures, we're going to see alterations in the nuclear and cytoplasmic cytomorphology of the squamous cells, which we denominate as coilocytosis. Those changes, as I just said, are more evident in mid to superficial layers of the squamous epithelium and should be identifiable at low power magnification. If you go to high power magnification too soon, everything is going to look atypical to you, and you're going to run into the risk of overdiagnosing LSIL. That's my approach. I start at low power magnification. If at that low power magnification, you can see nuclear enlargement, nuclear hyperchromasia, and at least an area that looks different or stands out from the adjacent normal squamous epithelium, then you pay attention and you want to get a closer look. And at that point, that's where you can confirm the presence of nuclear enlargement, hyperchromasia, irregularities in the nuclear membrane, which is basically within the spectrum of what we understand as coilocytic change. Those irregular nuclear membranes are usually described as racenoid nuclei with coarse chromatin, typically hyperchromatic. Binucleation or multinucleation is usually seen, And that's something, as I said, that you confirm at high power magnification. The presence of a perinuclear halo is quite characteristic, but it's not enough. You need to see nuclear enlargement, irregularities in the distribution of the chromatin, and the contours of the nuclear membranes, as you can see here. Binucleation or multinucleation is also characteristic. These features are going to be seen in the squamous epithelium, but for the most part, there is retention of that maturation pattern and differentiation into a mature squamous phenotype between the basal cell layers and the superficial aspects of the epithelium. We're going to talk about P16 and other ancillary tests throughout the talk, but I'm going to start with P16 at this point because it's relevant to LSIL, believe it or not. The first thing I want to say about P16 is I try to avoid reporting it as just positive or negative because people may not understand what you mean by negative or by positive. In this context, P16 is positivity is what we describe as P16 overexpression. So I usually use that term. Is P16 is positive / overexpressed, or P16 is overexpressed versus P16 is not overexpressed. And overexpression in this context is defined as strong cytoplasmic and nuclear staining in a block or spanning a continuous number of cells, usually full thickness in the squamous epithelium, but it needs to be at least present in the basal third of the epithelium. Again, as a continuous layer of consecutive cells showing strong cytoplasmic and nuclear positivity. Why am I mentioning P16 in the context of LSIL? Well, P16 is a very good surrogate for infection by high-risk HPV types. The majority of those lesions that are caused by high-risk HPV types are going to show P16 overexpression. The problem is a significant number of LSILs are caused by high-risk HPV. Up to a third of those lesions are related to high-risk HPV types and therefore are going to overexpress P16. There has been some literature showing certain differences in the clinical behavior of low-grade lesions that are negative for P16 overexpression versus low-grade lesions that overexpress P16 by immunohistochemistry. And it's been argued that the rates of regression are lower and the rates of persistence and HSIL outcome are slightly higher in those lesions that we classify on morphology as LSIL, but overexpress P16. However, these differences have not been observed in all series and are not statistically significant and do not really reflect the outcome that we see in bona fide HSILs. What I'm trying to say is that those LSILs that overexpress P16 are probably a little bit different, but not significantly different from the other LSILs that would not overexpress P16. And that's why we still understand them under the same basket. We still classify them as LSIL predominantly based on morphology. HPV detection studies in LSIL are relatively limited because 2/3 of LSILs are caused by low-risk HPV, and testing for low-risk HPV is not widely available. And detection of a high-risk HPV type does not exclude LSIL because 1/3 of those lesions are going to be caused by those high-risk HPV types. Proliferation markers are also relatively controversial because you may see extension of positive staining cells from the basal layer to the upper epithelial layers. CK7 has also been introduced in recent years as a marker of biologic progression or biologic significance in squamous intraepithelial lesions. It's positive in a minority of low-grade lesions, but those that are positive, according to early or emerging literature, apparently have a significantly higher risk of HSIL outcome. The problem with CK7 as a marker of the functional squamous columnar junction and as a biomarker of risk for HSIL outcome is the problem that is a problem of interobserver reproducibility and the fact that we're just starting to understand the role of a biomarker like CK7 in this particular scenario. So at this point, it's not recommended routinely, but I'm mentioning today because there's been literature in the past few years about it. I think the problem again is interrupts of reproducibility and the fact that there are a gradation of patterns that may be difficult to identify. This is the easy one where you see very strong diffuse cytoplasmic positivity for CK7, but not every single case abides by those type of expression patterns. This is a very nice graph from a reference textbook by Dr. Christopher Crum and Marisa Nushi and Ken Lee from the Brigham and Women's Hospital. This is the book I use to learn about GYN pathology. And what I like about this diagram is the fact that it illustrates the heterogeneity in the architecture of low and high grade lesions. Particularly the fact that the vast majority are going to be flat or and are going to show a mature phenotype, as we've discussed before. But there is a minority of lesions that will be exophytic or papillary or condylomatous, and there is a second of lesions that are going to display an immature metaplastic phenotype. Let's talk about those variants. Those variants that are exophytic or that grow in a condylomatous or papillary fashion can be mature or immature, and they have been described in the literature by several names. What's good about those is that most of those exophytic or condylomatous LSIL variants are related to low-risk HPV. The immature variants, or the variants that resemble immature squamous metaplasia, can be associated with low or high-risk HPV. The mature exophytic condyloma, which can be giant or can be referred to as what we call giant condyloma in other anatomic sites, is very rare, but can present as a clinically visible mass, and therefore raise concern for a cervical carcinoma. These lesions are characterized by marked acanthosis with a warty papillomatous appearance. Histologically, you'll be able to confirm coilocytosis, and they produce abundant or prominent exophytic growth, but there is absence of inward or endophytic growth into the cervical stroma. And you can see here, this is obviously something that you would expect to be visible clinically and obviously raise concern for a cervical cancer. However, you see the endocervical stroma here, and there's a sharp interface between the purely exophytic lesion and the spared cervical stroma underneath. This is a purely exophytic lesion that shows a mature squamous phenotype and is showing coilocytotic changes. Is an exophytic condyloma. There are other exophytic low-grade lesions that have been described under terminologies like papillary immature metaplasia or the so-called squamous papilloma. These lesions are usually related to low-risk HPVs. They will retain features of coilocytosis, but the squamous cell population will not look as mature. It will look like squamous metaplasia. You will identify it as a lesion because it's obviously papillary and exophytic, and it will show coilocytosis in the upper epithelial layers. There are two cases of the so-called inverted papilloma described in the literature, or both associated with this low-risk HPV type 42. They have been described as anastomosing trabecula with endophytic growth into the stroma and common glandular differentiation. I mention it because Dr. McLucas described it in 2012, but I've never seen one of these cases. Low-grade lesions that are flat and also display an immature metaplastic phenotype are difficult lesions, and let me say are quite controversial because they're difficult to diagnose. When you see something that is not maturing completely or is not resembling the maturation pattern of the normal ectocervix, you think of a high-grade lesion, right? And that's what has been questioned in the past. Are these really LSILs? Not only because they look immature and they're losing maturation, but also because there is an 8% possibility of an HSIL outcome at time of follow-up, which contrasts with the conventional low grades in which that outcome is lower when they're mature. Also, the rate of P16 overexpression in these so-called metaplastic LSILs is a bit higher compared to mature LSILs. This is an example of something that is not showing that maturation pattern and will overexpress P16, but we will classify as low grade based on morphology, based on the absence of severe cytologic atypia. I'm mentioning it because I think we should keep it in mind that there will be a subset of lesions that are morphologically low grade that will overexpress P16. And as I said before, I think those lesions should be treated conservatively because their outcome in terms of progression to malignancy is not the same as what we see with bona fide high-grade lesions. But it also illustrates how difficult this distinction can be sometimes. Now, the treatment of low-grade lesions is follow-up and co-testing based on the most recent guidelines. It will largely depend on whether the biopsy with a diagnosis of LSIL was preceded by negative or LSIL cytology or abnormalities, or whether it was preceded by an HSIL cytology or higher grade abnormalities, in which case a review of all the findings and diagnostic decisional procedures will be considered. The differential diagnosis of LSIL is wide. We're going to review some of these entities now. Reactive atypia in the cervix is quite frequent, usually in the context of squamous metaplasia or marked inflammation. The presence of enlarged nuclei, binucleation or multinucleation, and increased mitotic activity should all make us think of a low-grade squamous intraepithelial lesion. However, in the context of reactive atypia, we see uniform nuclear sizes. The chromatin is not hyperchromatic or coarse, it's hypodense, and we can see a nucleolus at high power magnification. Increase your threshold and be very wary of areas of the cervical mucosa that are disinflamed. When you're in the setting of very dense inflammation, the population is going to look less mature and you're going to see nuclear enlargement. However, if you don't see the nuclear membrane irregularity, if you don't see the coarse hyperchromatic appearance of coilocytic nuclei, think of reactive atypia. Identifying nucleoli at high power magnification is usually very helpful. And that overall hypochromatic look of the nuclei is also very, very helpful. If I see neutrophils or acute or chronic inflammatory infiltrates percolating throughout the epithelium, I also raise my threshold. It's probably atypia unless I see really, really good coilocytosis. Something that I actually see more frequently, this misdiagnosed as low grade, is just the physiologic effect of estrogen in the squamous epithelium, which we call glycogenation. The accumulation of glycogen in the mature squamous epithelium during reproductive age causes that basket weave appearance with the formation of this very distinct perinuclear halus that in the setting of subtle hyperchromasia, subtle nuclear enlargement, may make us think of a low-grade lesion. However, you shouldn't see significant nuclear irregularities in the nuclear membrane or in the chromatin distribution pattern. This is something that you will then maybe catches your eye because of the diffuse presence of perinuclear halus, and the nuclei may be a little bit large compared to the ones in the surface. But if you can see here, the nuclear chromatin distribution is not irregular, and the nuclear membranes are pretty smooth throughout. This is just the normal glycogenation pattern of mature squamous epithelium. Very uniform nuclear population, don't overdiagnose it as LSIL. Radiation-induced changes can be seen not only in squamous and glandular epithelium, but also in the connective tissue around it. Be aware that they can happen years following pelvic radiation, so that history may not be immediately available to you. They're degenerative in nature, but they can be worrisome because they feature enlarged nuclei that can appear hyperchromatic. However, that hyperchromasia is more due to this smudge chromatin appearance, not really coarse or granular, which is what we expect to see in a lesional or neoplastic process. The nuclei grow in size, but also does the cytoplasm, so the nuclear to cytoplasmic ratio remains low. We see scant mitosis and look for similar changes in the underlying stroma, vessels and fibroblasts. Sometimes biopsies from these patients are not ideal. They're very fragmented or crushed because their anatomy after, in the context of radiation can be quite distorted. These nuclei are atypical, but you can also appreciate the abundant foamy or bubbly granular cytoplasm, which is a hint. And you see similar atypical changes in stromal cells or in endothelium, like in this case. All that and supportive of, if you have the history, that will all be supportive of the diagnosis of radiation-induced atypia, which is a benign diagnosis. I mentioned the term squamous papilloma before because it was common in the old literature pre-HPV era. I don't think it really exists as an entity because most exophytic or papillary or condylomatous lesions in the cervix are indeed related to HPV infection. So I would avoid the term because squamous papilloma is something that we would understand in other anatomic sites as independent from HPV infection. High-grade squamous intraepithelial lesions are also prevalent in reproductive age women, slightly older in average when we compare them to low-grade lesions, and the incidence in younger women is increasing in most societies. The hallmark of an HSIL or high-grade squamous intraepithelial lesion, as I briefly mentioned before, is the significant impairment in cell differentiation and maturation of the squamous epithelium. Therefore, we're going to see changes in the morphology of the cells, not only as the cells mature, but also at the basal and parabasal cell layers. In the lower layers, we're going to see increased nuclear density, pleomorphism, and atypia, loss of polarity, and that's usually something that is that catches your eye at low power magnification. In this particular section, we can see that this area of abnormal squamous proliferation is right at the squamocolumnar junction, which is where the vast majority of these lesions arise. And in this particular micro photograph, we can compare the normal, the squamous epithelium to the lesional area, not only in the way it matures and the cells differentiate from base to top, but also in the organization and the overall nuclear size of the cells at the basal layer in the squamous epithelium here on your right, and the dysplastic squamous epithelium on your left. You can see that the basal cell layers are not organized anymore. The nuclear enlargement is quite significant. In this particular lesion, you can see very brisk mitotic activity that is not confined to the basal layers anymore. It extends to upper epithelial layers. Because the lesion is not maturing or has incomplete maturation, you're going to see those atypical nuclear features in upper layers as well, with high nuclear to cytoplasmic ratio and persistence of mitotic activity. And that's an example. This is an example of another HSIL with brisk mitotic activity extending towards the surface. And you can see that the nuclear size and the irregularity and the atypical features of those nuclei are present both at the base and at the surface. This lesion is really not maturing the way normal squamous epithelium should. Just like low-grade lesions, we can see a spectrum architecturally and cytologically in high-grade squamous intraepithelial lesions. The conventional HSILs are those that show a mature squamous phenotype that is significantly impaired, but there are lesions that are going to highly resemble immature squamous metaplasia, and those have been termed immature metaplastic high-grade squamous intraepithelial lesions. I'm also going to talk about thin HSIL in a second. High-grade lesions that highly resemble immature squamous metaplasia are deceiving, as you can imagine, because they tend to have more abundant cytoplasm and more subtle nuclear atypia. However, they're going to retain that immature look, and they're going to have higher nuclear density. And unlike immature low-grade squamous intraepithelial lesions, they will have more evident nuclear pleomorphism with loss of organization, marked nuclear overlapping, importantly, in the lower epithelial layers. And that's, again, a primary morphological diagnosis. This is a lesion with metaplastic look. It make you think of immature squamous metaplasia, but hopefully you can appreciate the loss of organization, overlapping, and nuclear enlargement that correlate with P16 overexpression and a high-grade phenotype. The so-called thin HSIL has come into the classification because it's a bit different and a bit challenging compared to conventional HSILs. Most high-grade lesions will have a normal thickness or an increased thickness compared to the normal ectocervix, usually 10 cell layers or more. Thin HSIL is defined as a lesion that has a thickness of less than 10 cells or 10 cell layers. And because of that, the low power magnification can be deceiving and highly resemble squamous atrophy. However, at high power magnification, you should be able to identify mitotic activity, nuclear overlap, loss of organization, nuclear membrane irregularities, and nuclear enlargement. Let's go back to P16, which in contrast to LSIL, is present in the vast majority of high-grade squamous intraepithelial lesion. Not surprisingly, because the vast majority of HSILs are caused by high-risk HPV. Because of this, P16 immunohistochemistry has a high negative predictive value for the diagnosis of HSIL. In other words, if it's negative, it pretty much excludes the possibility of an HSIL. With very rare exceptions. It will not work all the time, but most times it will pretty much raise confidence in the diagnosis of that is not an HSIL if it's not overexpressed. P16 promotes synthesis of the retinoblastoma protein, or RB, which in turn binds to this molecule E2F to stop cell cycle progression. And that's why high-risk HPV is oncogenic in nature, because by binding to RB, the oncoprotein E7 produced by HPV inactivates RB, therefore causing an increase of the molecule E2F, which will promote the cell into going to subsequent cell cycles. The increased E2F levels are also going to lead to increased synthesis of P16, which is going to try to counteract that active cell cycle progression. And that's why we see P16 accumulation in both the nuclei and the cytoplasm in cases infected by high-risk HPV. Now, the treatment of HSILs is, in most circumstances, is colposcopy and a diagnostic excisional procedure. However, I'm including this algorithm from the latest guidelines by the American Society of Colposcopy and Clinical Pathology, because there are certain instances in which a diagnosis of HSIL will not lead to a surgical excision. Patients that are pregnant or that are younger than 25 years of age will have different considerations. Those patients will be considered for observation instead of diagnostic excisional procedure, particularly if the diagnosis of CIN2 is specified. Why? Because the rates of regression or resolution in that patient population, patients younger than 25 years of age, is significantly higher if the lesion is a CIN2. Also, if the patient is pregnant, or if future pregnancy is a high concern, and you really want to avoid a diagnostic excisional procedure that will basically take portions of the cervix out, right? So what about CIN2? Why is CIN2 still in the picture? It really begs the question, because we know for a while that there's a high agreement in the distinction between HSIL and LSIL, and that binary classification has good inter-observer reproducibility, and that's why the recommendation now stands to treat these lesions in this binary classification of LSIL versus HSIL. And on top of that, the diagnosis of CIN2, or moderate squamous dysplasia, has highly variable inter-observer agreement. The kappas are not nearly as good as in the distinction between LSIL and HSIL. And it's for those reasons a diagnosis that is difficult to make. However, and for those reasons, we should start with the recommendations for terminology, stratifying lesions as LSIL or HSIL. However, there are certain clinical situations, as I just mentioned, in which mentioning whether a HSIL lesion is CIN2 or CIN3 may matter for treatment and follow-up purposes. So if the woman is younger than 25 years, or your colleagues ask you to make the effort to classify the lesion as CIN2 or CIN3, because it may matter for management purposes, then we should try to make that distinction. Fortunately, this is going to be even more rare in the future, because screening is going to start at the age of 25 years. So this population, or the possibility of having a patient that is younger than 25 years with a diagnosis of HSIL is going to become more infrequent. However, we're still going to see it. And if our clinicians want us to make that distinction because it may matter to the patient, rely on morphology. I usually classify something as CIN2 if I see partial or partially retained maturation, when the mitosis extends only to the two lower thirds of the epithelial thickness. I will favor something to be CIN3 when there's complete or subtotal loss of maturation and the mitosis extends to the full thickness of the epithelium. This is something that I will classify as CIN2 because I see high-grade features, particularly at the base, but there is retained maturation, as you can see here, comparing the base from the top. The HSIL has also a wide differential diagnosis, including distinction from low-grade lesions, which we're going to briefly go back to. I think I've already given hints to this, but the distinction between low-grade and high-grade lesions is primarily morphologic. P16 can help you if it's negative, because it will argue against an HSIL. However, P16 overexpression, it won't really help you because it's seen in about a third of lesions that are morphologically and biologically low grade. Therefore, keep a high threshold for ordering P16 and try to use your morphologic approach to distinguish those lesions as much as possible. And for that distinction, I really concentrate on the lower third, because high-grade lesions usually show more evident changes of nuclear atypia in the lower epithelial layers and the progressive loss of squamous maturation that I've mentioned before. Now, is there an intermediate category, or is there a group of lesions that we won't be able to reliably classify as low or high grade? And to me, the answer is yes. And in the several practices, we use several names for it, either as a squamous intraepithelial lesion unclassifiable, or squamous intraepithelial lesion not amenable for grading. I do think that some lesions will fall into this category, but keep in mind that this term, or this gray zone area, this middle term, is not reflected in the clinical guidelines. So I always do my best to favor a definitive diagnosis, either low-grade or high-grade lesion, mostly based on my H&E impression, as I said before. I would consider doing P16 because it will help me if it's negative, and it will support a diagnosis of LSIL. Consider deeper sections and consultation with your colleagues to do your best to try to classify something as low-grade or high-grade. But keep in mind that some lesions, especially suboptimal biopsies, will fall into this category. And I use the term when I cannot really for sure classify something as LSIL and HSIL. In most cases, the clinicians were going to follow that patient and probably bring her back for repeated sampling sooner rather than later. Squamous metaplasia is probably the most common differential diagnosis of a high-grade lesion. Is a physiologic event that we see in the transformation zone and can be immature or mature. When squamous metaplasia is fully mature, is going to be exactly the same morphology as we see in the mature ectocervix. It's just that it's now present in the compartment that was previously endocervical in nature. Immature squamous metaplasia will often involve the endocervical glands and is going to show lesser degrees of squamous maturation. However, is going to retain that nuclear uniformity that we expect to see in a benign lesion. Don't be fooled by the incomplete maturation. and by the mitotic activity in basal cell layers. Look at the nuclear morphology, look at the absence of nuclear membrane irregularity and the absence of coarse or irregular hyperchromatic nuclear distribution. P16 can help in these cases if your differential is with a high-grade lesion, because it should be negative for P16 overexpression if it's a metaplastic process. You can see the nuclear enlargement here, but it's not associated with irregularity in the size of the nuclei or irregularity in the shape of the nuclei. And there is retained organization as the base and as the population matures towards the surface. Cautery artifact may look these areas even more worrisome than they really are. I usually avoid interpreting things at the cautery edge, and I move to areas that are better preserved. Squamous atrophy, which is also almost a physiologic change that we see usually in the setting of postmenopause, but also in other settings where the estrogen levels are really low, can be confused by an HSIL because they're going to show what's happening. Give me 1 second. My computer decided to freeze. Sorry, my computer just decided to shut out the presentation. So just give me 1 second. Do you think, are there any questions in the chat that I can answer while I reopen this? Sorry, guys. This has not been a morning to where technology has helped us. Do you think, are there any questions in the chat?
Oh yeah, there are a lot of questions. Should I read them, Carlos?
Yes, maybe read me one, and then while I wait for the PowerPoint.
Okay. Yeah, there is one question. In case of morphologic dilemma between LSIL versus ACIL, and when P16 shows shade variation between superficial and basal layers being more strong, do you still interpret them as block staining and favor ACIL?
Yes, the definition of P16 overexpression states that the strong expression or the overexpression can be limited to the basal and parabasal cell layers, can be limited to the lower third. So yes, it doesn't need to span the entire thickness. As long as it expands, as long as it continues, in other words, every single cell in the basal and parabasal cell layer is showing a strong nuclear and cytoplasmic expression, I would call that overexpressed. And if you're wondering whether that's LSIL or HSIL, as I said before, that P16 overexpression wouldn't really help you. But as long as you see continuous nuclear and cytoplasmic, I emphasize on the words nuclear and cytoplasmic because if they're part of the definition. I pay a lot of attention to nuclear expression of P16. Sometimes there's a lot of P16 background in lesions that are not associated with HPV, and they may look like they're overexpressed. But if it's mostly cytoplasmic and there's very little to no nuclear expression, I would not count it as overexpressed.
Right. Yeah, do you have time for another one, or is it back?
Please. Yeah, my PowerPoint's not working. So yes, I'll have another question.
Yeah, on that line, I want to add a question from my side, because like on GI pathology also, when we look at the anal lesions, squamous lesions, we run into these issues with P16 interpretation. The question is, as you said, that some of the low-grade lesions can also express P16, right? So if there is P16 expression or block expression, and on H&E it looks more like low grade. So what is your advice on that? How do you approach that?
Well, so yeah, good question. If I see something that looks like a low grade, but happens to come with a P16, or somebody did a P16, or I did a P16, and now the P16 is overexpressed, but I still have doubts about calling that high grade. I would probably get consensus from my colleagues if I can show that case to somebody. If there is still concern about that lesion being a low-grade lesion, I will report it as a low-grade lesion. And I would mention the fact that it overexpresses P16. Mostly because there is literature showing that P16, as we've mentioned before, P16 is a marker of high-risk HPV. Doesn't necessarily mean that that patient is going to come back with an HSIL. But I will report it. I will say squamous intraepithelial lesion favor low grade, and then say that P16 immunohistochemistry shows overexpression. However, morphologically, the lesion does not have definitive HSIL features. I think that matters most importantly in the young patient category, as I said, because even if that lesion is high grade, the rate of, or the chances of that lesion regressing or resolving within 1 year are significantly higher in the young patient population, younger than 25 years of age. So if you're dealing with a young patient, I will be more conservative, and I will pull away from calling something high grade, especially if it's just based only on the P16. Hopefully that helps. In a nutshell, I use morphology, and I base my impression on morphology as much as I can.
Right, thank you. Are you back, or you want to take one more question?
Yeah, give me one more, because yeah, I have time for one more question.
So another question from one of our viewers is that, do you recommend the use of P53, and how do you interpret P53 for squamous lesions of the cervix?
Interesting question. I don't usually do it, and I confess I don't know much literature on P16 in squamous intraepithelial lesions of the cervix. P53, it's a common marker that we see in squamous intraepithelial lesions of the vulva, because in the vulva we have this segment of squamous intraepithelial lesions that are not related to HPV, and they are associated with P53 abnormalities. That's not the case in the cervix, or at least not with the same proportions. We acknowledge, and the WHO acknowledges, that there is the possibility of encountering a squamous intraepithelial lesion that is negative for HPV, and therefore is going to be negative for P16. But I don't think we know that that entity for sure is characterized by P53 alterations. So for those reasons, I never do it. I would consider there's been very few instances in my practice in which we've come across something that looks HSIL on H&E. Like for sure, it's very convincingly it's very convincing for HSIL morphologically. But someone decided to do a P16, and the P16 comes back as negative, right? Which basically is a reinforcement of this concept that HPV negative HSIL lesions can happen in the cervix, but they're exceedingly rare, and maybe that will be the only instance in which I would consider throwing a P53. But even then, I wouldn't know what to do with it because to the best of my knowledge, there's not much evidence or literature on it. So at this point, I will feel more towards not doing it, not getting into trouble. Okay.
Are you back? Yeah,
yes.
Great. Okay, thanks.
Let me share.
Thanks.
I'm so sorry, guys. Let me share my screen again. Are you seeing my screen, Rifat?
Oh yeah, it's back.
Okay,
Yeah.
awesome.
Okay.
I was talking about squamous atrophy before this thing crashed on me. Morphologically can look like an HSIL, or thin HSIL can look like atrophy because they're both thin. They don't have the maturation pattern. They're going to look very hypercellular. However, and you're going to see an increased NC ratio because most of the cells are baseloid and don't really acquire much cytoplasm as maturing cells do. However, in the setting of squamous atrophy, the nuclei are going to be very small and uniform, nicely organized, and mitosis are going to be rare, usually absent. You can also consider P16 in this setting. Transitional metaplasia is a part of the spectrum of squamous atrophy to some people because it's typical of postmenopausal women. Unlike conventional squamous atrophy, transitional metaplasia tends to be thicker, and it features characteristics that we associate with urothelial or transitional type epithelium, with vertical orientation of the nuclei towards the lower layers and horizontal orientation of the nuclei in superficial layers. You can see umbrella-like cells as well. And these characteristic, very nice intranuclear grooves in the squamous cells are also very characteristic of transitional type metaplasia. They usually appear as incomplete squamous maturation, so that would make you think of an HSIL. However, look for the different nuclear orientation between basal and superficial layers, the oval to elongated nuclei with longitudinal grooves, uniform nuclear contours, and rare mitosis. P16 will also be negative for overexpression in this setting. Transitional metaplasia is consistently positive for CK7, but negative for CK20 when encountered in the cervix. The last lesion I will mention here as a differential diagnosis of HSIL is what we understand as SMILE, or stratified mucin-producing and you're going to see absence of squamous differentiation at both high and low power magnification. We understand SMILE lesions as adenocarcinoma in situ stratified variants as per the most recent WHO classification. You can see how something like this will make you think of a high-grade squamous intraepithelial lesion at low power, but at this magnification, we can see the very nice intracytoplasmic mucinous profile of all these cells throughout the epithelial thickness, right? All of these cells are lesional, but are containing abundant intracytoplasmic mucin, which should make you think of a SMILE lesion. There's this very rare concept of adenosquamous carcinoma in situ. I've never seen one in real life, but in theory, you should, if it's in situ, just make sure that it's superficial or confined to endocervical crypts, number one. And number two, where you see intimately admixed squamous and glandular dysplastic epithelial elements. Probably what you're going to see most frequently in practice is just HSIL coexisting with an adenocarcinoma in situ. They're closely associated. You can see it within the same fragment, but but you can have a nice demarcation between the two lesions. That's probably what happens in most cases. Metastatic carcinomas can, on occasion, mimic an HSIL when they're confined to the epithelial compartment. That's usually in what we see in the setting of extramammary Paget's disease from the vulva, for example, that can colonize the vagina and eventually the cervix. I'm going to talk also about the equally rare event of urothelial carcinomas that spread to the cervix, also in a Pagetoid fashion. The primary is usually located in the bladder and can be non-invasive. It can be a non-invasive papillary carcinoma or a urothelial carcinoma in situ, and again just spread through a pagetoid fashion into the vagina and then eventually the cervix. Because the spread is pagetoid, they're going to simulate an in situ lesion, HSIL or adenocarcinoma in situ. The cytomorphology is going to resemble or pretty much mimic the morphology of the urothelial primary, which can be low grade or high grade and can have squamous or glandular differentiation, which doesn't really help, because if it has squamous or glandular differentiation, it's going to look pretty much like a cervical primary. And in those cases, the diagnosis can be quite difficult. Fortunately, in most of these cases, there's a known history of urothelial carcinoma. Most of these cases had urothelial carcinoma in the past or diagnosed concurrently with the cervical lesion. So if that's the case, if you have someone with a history of urothelial carcinoma, consider this diagnosis. And as you can see here, these cases can show glandular differentiation, which can be quite tricky. Be wary of the fact that urothelial carcinomas can overexpress P16, particularly if they're high grade. If you have the ability of performing HPV studies, you can do them because urothelial carcinomas should be negative, although HPV positive categories also exist. And I'm not expert on that, just for the record. GATA3 is strong and diffuse in urothelial carcinomas, but importantly has lower expression in carcinomas with squamous or glandular differentiation. So don't expect GATA3 to be always positive. Rely on the clinical history and have a high diagnostic threshold. Let's move quickly to invasive carcinoma of the cervix, which is unfortunately still a very morbid and fatal disease, particularly in mid to low income countries. We've seen stark progress in developed countries thanks to very successful screening programs, but we haven't seen the same in developing countries worldwide, in which cervical cancer is still the leading cause of cancer-related death, and 90% of deaths due to cervical cancer come from those countries. So this is still a pretty much important disease for us to know about. The diagnosis of stromal invasion relies on a series of cytologic and architectural features, not only in the squamous cell population, but in the surrounding stroma, which is typically desmoplastic or fibromyxoid. We expect to see paradoxical maturation of the epithelial cells, loss of polarity and basal palisading with a markedly irregular and convoluted epithelial stromal interface. So let's go over some of those features. I diagnose stromal invasion when there is a significant stromal desmoplasia, as you can see here, and when you see a nesting of the squamous cells, but with the shape and with a size and with a distribution that will be far beyond what I would expect in a HSIL involving endocervical crypts. As you can see here, these nest outlines are too irregular, too sharp in areas, too convoluted for me to think that they're endocervical crypts involved by a squamous epithelium. Desmoplasia can be seen in high power as these reactive stroma with plump fibroblast cells in a fibromyxoid matrix with variable inflammation. When the squamous cell neoplasms of the cervix invade, they like to show what we call paradoxical maturation, which is the appearance of abundant cytoplasm, which is typically eosinophilic when they invade. We call it paradoxical because that's usually something that we see in the surface as the squamous cell population matures. Well, they also do that when they start invading to the surrounding stroma, and it catches our eye because it's in stark contrast with the rather basaloid population of non-maturing squamous intraepithelial lesions confined to the intraepithelial compartment. You can see that loss of organization and that paradoxical maturation of early stromal invasion in this particular case. Again, look at the distribution of the nesting. This population particularly is not showing squamous differentiation, is not showing paradoxical maturation, but nobody would call this in situ because the architecture and the distribution of the nesting is very irregular and confluent. When you find stromal invasion, well, how do we measure it? It depends on whether you're seeing adjacent in situ lesion to the invasive population, in which case you measure from the base of the epithelium from which carcinoma arises, or from the nearest dysplastic crypt or surface involved by HSIL. If there is no obvious epithelial origin, measure from the base of the nearest surface epithelium and report the cervical wall thickness. This is an invasive process in which I decided to measure from the nearest, most superficial in situ interface here to the deepest point of invasion. In cases where stromal invasion is quite early, again, you locate the nearest endocervical gland or the nearest endocervical crypt containing an in situ lesion. In this case, for this particular nest, it will be this one. For this particular nest, it probably will be this one. You report whatever is great, the greatest depth of invasion following those parameters. Mimickers of stromal invasion in histologic sections are many. We're going to cover some of this. Tangential sectioning is quite frequently, particularly in small biopsies or very fragmented excisions. Try your best to establish tissue orientation. Look for paradoxical maturation or irregular contours of the nest and perform deeper sections if you are not sure. Previous biopsies can be quite deceiving because you're going to see this plastic displaced neoplastic epithelium that can show sometimes maturation patterns. For example, here you have the in situ lesion at the top, and then you have this nest of squamous cells that seem to be maturing. You will think they're invasive because they are showing quote unquote paradoxical maturation, but we're in a heavily inflamed area that contains giant cells. So probably it was an area that was disrupted, usually by previous biopsy or previous excisional site procedures. So move away from these areas. I would not count neoplastic squamous elements that are associated with heavy hemosiderin deposition, reactive fibrosis, or giant cell reaction because they're probably displaced in nature. Intense inflammation can obscure an invasive process, but can also distort the epithelial stromal interface. So I try to assess stromal invasion in areas that are not as inflamed, but look for that paradoxical maturation and the regularity of the contours to diagnose stromal invasion. Crypt involvement by HSIL will show the persistence of that basaloid palisading that you see in lesions that are still intraepithelial. You're not going to see irregularity in that contour or paradoxical squamous maturation. Something that really helps if you have it is look at the adjacent endocervical crypts, look at the size and the distribution of those crypts, and then go back to your squamous proliferation to see if it mirrors or it simulates the distribution and the architecture of the normal endocervical compartment. Some lesions are very suspicious for stromal invasion, but are not definitive for it. And I always like to mention this study is not relatively old, it's very old, but it's very nice. And unfortunately, I don't know if more elegant follow-up studies on this, but what the study illustrates is that all cases in which stromal invasion was suspected but not confirmed, in other words, you're suspecting very early stromal invasion, less than 1 millimeter in depth, but you cannot confirm it, those lesions tend to behave like an HSIL lesion. In other words, keep a high threshold for calling something stromal invasion. Even if you find areas that are suspicious, if you're not convinced, don't call it flat out invasion because those lesions are more likely to behave like an HSIL and are not going to have a carcinoma outcome if they're excised entirely. There are several types of invasive squamous cell carcinoma. We know that most of these descriptions are morphology based and do not correlate with the biology of the lesion. So describing squamous cell carcinoma of the cervix as keratinizing or non-keratinizing or warty or verrucous or lymphoepithelioma-like doesn't have, at least for now, significant biologic or clinical connotations. It's just for us to know that the morphologic appearance of squamous cell carcinoma is quite wide. Usually we try to make the distinction between keratinizing and non-keratinizing squamous cell carcinoma by the presence of abundant eosinophilic cytoplasm and evident intercellular junctions or the presence of keratin pearls. And when we see something that is keratinizing, we should also, well, we jump into the conclusion that is a keratinizing squamous cell carcinoma. And in most instances, we're right. However, we should keep in mind that there is always a differential diagnosis. And in the setting of something that looks keratinizing, I always try to rule out the presence of an adenosquamous carcinoma, which is not that infrequent. If you look at series showing us that about 5% of cervical malignancies fall into this category of adenosquamous carcinoma, also caused by HPV of the high-risk types. This diagnosis requires the presence of closely admixed areas of glandular and squamous differentiation within the neoplasm. The squamous component is usually poorly differentiated, so it's going to have a lot of solid growth. It may not look squamous at first glance, but the glandular component is usually better seen because it retains lumen formation, intracellular mucin, and columnar shape of the cells, which is something that you can see at low power magnification. You should see the presence of definitive glandular elements coexisting with definitively squamous elements on H&E. Adenosquamous carcinomas are also characterized by P16 overexpression, but they may have variable expression of glandular and squamous markers. We try to identify adenosquamous carcinomas because they tend to behave in a worse fashion compared to squamous cell carcinomas, and in some cases, particularly advanced stage, worse than most HPV-related adenocarcinomas. So there is some evidence mounting to the fact that these lesions tend to be more aggressive, and that's why we keep that diagnosis in mind. Glassy cell carcinoma is understood by some as a variant of adenosquamous carcinoma, typically seen in young patients. Is a poorly differentiated tumor by definition, in which we see very large cells with abundant eosinophilic ground glass cytoplasm and no evident squamous or glandular differentiation. Some people classify this as adenosquamous cell carcinomas because of their electron microscopy findings. When you see something that grows in solid sheets or nests, is not really showing definitive squamous cell differentiation, but instead has this abundant cytoplasm of the cells with ground glass appearance. Think of glassy cell carcinoma. These lesions are characterized by an aggressive clinical course, which is significantly worse than conventional squamous cell carcinomas. Other trophoblastic lesions will also fall into the differential sometimes of squamous cell carcinomas and glassy cell carcinomas for that matter. We're going to talk about placental site nodule, which is usually the most common, incidentally found because these lesions are microscopically or very, very small, up to 1 centimeter, seen as nests of intermediate extravillous trophoblasts, characteristically admixed with fibrinoid material and sometimes decellulized stroma, which are helpful features. This was a rather large placental site nodule that I encountered in practice. You see those epithelioid cells that are forming nests, will make you think of a squamous proliferation, but it's associated with this abundant fibrinoid in the background, and these cells may look cytologically atypical if we apply squamous epithelial standards, but the morphology of the cells and the smooth contours of the nodularity and the presence of this fibrinoid material around it should make you think of a placental site nodule. Keep in mind that these lesions can be P63 positive, just like squamous cell proliferations. However, they're also positive for trophoblastic markers, including GATA3, also HPL, MELCAM or CD146 and inhibin. And the Ki-67 proliferation index of placental site nodules is low, is less than 10%, whereas squamous cell carcinoma will have higher Ki-67 proliferation indexes. Basaloid squamous cell carcinoma is rather rare. It elicits a slightly different differential diagnosis, particularly HSIL involving endocervical crypts, as we said before, but also certain types of basaloid epithelial proliferation. Basaloid squamous cell carcinomas are not going to show paradoxical maturation, but are going to nevertheless show a squamous phenotype. On morphology and immunohistochemistry, you can see that the irregularity of the contours as this lesion grows into the cervical stroma, diagnosis of destructive stromal invasion. When we see basaloid squamous proliferations, we also think of adenoid-basal carcinoma, which is a special type of neoplasia in the uterine cervix, typical of postmenopausal women, frequently associated with HSIL and also caused by high-risk HPV. What's characteristic about adenoid-basal carcinoma is that when it's found purely, or the lesion is entirely composed of adenoid-basal morphology, these lesions have a very indolent behavior. Complete excision is curative in all these cases, to the point that some people believe that they're benign and should be called adenoid-basal epithelioma. Now, the term adenoid-basal carcinoma persists in the classification, but keep in mind that these lesions can be quite indolent if they're pure. Sometimes they're admixed with a conventional squamous cell carcinoma or a conventional usual type adenocarcinoma. And in those cases, the prognosis is going to be dictated by that component. The pitfall here is the haphazard distribution of the nests, which make us think of an invasive process. They are probably, in a way, invasive processes. However, you have a basilar organization at the periphery. You can see squamous or glandular differentiation, but you see that in the center of the nest and not at the periphery, which would be the case with in the setting of a squamous cell carcinoma with paradoxical squamous maturation. These adenoid-basal carcinomas do not have this stromal desmoplasia and they usually not have lymphovascular space invasion or perineural invasion. If you see LVI or perineural invasion, you're probably dealing with a squamous cell carcinoma component associated with an adenoid-basal carcinoma. This is the typical appearance of these lesions. Very haphazard, deep distribution of the nest throughout the cervical stroma. However, you appreciate the stroma is not desmoplastic, and the outline of this nest is very basaloid. In the center, you're going to have areas of glandular or squamous differentiation, as you can see here in this microphotograph. Very nicely central squamous maturation or glandular formation, but the periphery of the nest remains basaloid. Adenoid cystic carcinomas in the cervix are quite rare, but be aware that they exist. In the lower genital tract, they're more frequent in the vulva, and they can be associated with HPV or they can be negative for HPV, particularly if they found in their pure form. Adenoid cystic carcinoma can be pure or can be an adenocystic component of something that is either squamous or adenocarcinoma in nature. And those lesions tend to be associated with HPV. They have similar morphology to the adenocystic carcinomas that we see in other anatomic locations. They're going to be basaloid, but they have the typical cribriform, tubular, or solid growth patterns that we see in adenocystic carcinomas. The cystic areas contain mucinous or eosinophilic secretions, and the pseudocystic areas contain basement membrane-like material. These lesions are negative for hormone receptor, and at least in other areas have been demonstrated to have c-KIT expression and MIP expression, which correlates with the typical mutations that we see in the head and neck region. This is the typical morphology of an adenocystic carcinoma of the cervix. Is pretty much the same that we see in the head and neck region or the breast, where they're more frequent. These lesions can overexpress P16 if they're related to HPV, but will also show the expression of myoepithelial markers as we see in other anatomic locations. There are other variants of squamous cell carcinoma, particularly when they're exophytic. We have terminologies for that: papillary or squamotransitional, warty or condylomatous, verrucous carcinomas. In these cases, the differential diagnosis is with an in situ lesion, in which case the underlying cervical stroma will be spared, and there will not be significant cytologic atypia. This was a squamotransitional papillary squamous cell carcinoma with a very distinct nuclear morphology. The last two variants I'm going to mention is the lymphoepithelioma-like carcinoma, which is highly uncommon. It resembles what we see in the nasopharyngeal lymphoepithelioma-like squamous cell carcinomas of the head and neck region. Unlike those tumors, tumors described in the cervix are not related to EBV infection, and the role of HPV infection is at most unclear at this point. And they're very poorly differentiated, and they're obscured by the presence of this very heavy lymphocytic infiltrate. The last variant I'm going to mention is the spindle cell or sarcomatoid squamous cell carcinoma, which usually predominates and can be indistinct with no definitive lineage differentiation. However, rare cases of osteoclast-like or smooth muscle differentiation have been described. These lesions are positive for HPV, just like the squamous cell carcinoma of the conventional type. And when we find it, we're usually going to confuse it with a typical or frankly malignant mesenchymal proliferation, like a leiomyosarcoma. This is a case I had a few years ago that presented as a very bulky uterine cervical mass. And you can see it has a very nice spindle, almost fascicular appearance, very atypical. It expressed smooth muscle markers, interestingly, and it was first misdiagnosed as a leiomyosarcoma. However, you can see the very strong cytokeratin expression, which led us to test this tumor for HPV studies and turned out to be positive. Further sampling identified areas of more conventional squamous cell carcinoma. So I want to conclude with this case just to make you think that if, just like in the breast, if you see something that is a spindle cell in the cervix, always keep in the back of your mind that it could be a squamous cell carcinoma with sarcomatoid or spindle cell differentiation. With that, I don't know how well I'm doing with time, probably not very well, but I want to thank you for your attention. In previous podcast lectures, I had my old work email address. You can forget about that one because this is my new email address. I'll answer questions right now if we have time. If not, just shoot me an email and I'll be happy to try to answer your question.
Thank you, Dr. Parra-Harran, for this excellent discussion on one of the very important topics in GYN pathology, even though, and as you can appreciate from so many questions from the viewers who were so enthusiastic. So there is, before that, so there's something for you, like I probably will have to quickly leave for another meeting. So do you think you can read the chat? And I have posted some questions on the chat box. So can you check the chat box?
I see Zoom the chat box. Yeah, I'm seeing it. Do you want me to answer those now?
Because like, I will just read one question from YouTube. So maybe you can continue with the other questions. So the one question that I see here is that, do you recommend doing P16 in all squamous carcinoma of the cervix for the purpose of classification, since it does not have any therapeutic implications?
Yes, thank you, Ripat. My answer to that will be no for now, because again, it's similar to what we're seeing in the vulva, because in the vulva, P16 seems to have a prognostic role, and maybe in the future, a therapeutic role. Because there's this other segment of squamous cell carcinomas of the vulva that are HPV negative and are worse players. In the cervix, as far as we know, that's not the case. In the cervix, the overwhelming majority of squamous cell carcinomas are related to HPV, and they will all show P16 overexpression. So the P16 in the cervix doesn't have a prognostic role. And I don't really do it. Not if I'm sure it's a cervical primary. Yeah. Okay, I'm gonna read some of the questions that Rifat posted in the chat. Is HSIL helpful in distinguishing between cautery artifact and HSIL? I've done it in the past, but keep in mind that the cautery artifact can also hinder your interpretation of the stain. In other words, it may be very difficult to interpret the staining for P16 in the area of cautery. I've done it a couple times, and I think in one of those cases I favored P16 because it was very, very strong. I could still appreciate that there was nuclear and cytoplasmic, so I favored the possibility of HSIL. But I've had other instances in which I couldn't really tell whether it was overexpressed or not, precisely because of the cautery artifact. So it doesn't really help all the time in my experience. Any clues on tips to differentiate florid SIN3 in crypts and C3-like invasive squamous cell carcinoma? Thank you. I think I gave you most of my tips. I really look for paradoxical maturation, and I also look at the complexity or the simplicity of the nest and the distribution of the squamous proliferation. If I have the normal endocervix adjacent to it to compare, that usually helps me a lot. If I'm looking at a well-oriented section, that helps a lot. If you're looking at something that could be tangentially sectioned or embedded on an angle, be aware of that. I don't do basal membrane immunohistochemistry in that setting, and I don't know anybody that does that on a routine basis. If I am not convinced it's invasive, I just let it go as suspicious for invasion, but not diagnostic for it. So hopefully that helps. Any use of CK7 in HSIL? It's been proposed, and as I mentioned it, I think there is growing knowledge on the role of CK7. My understanding is that the majority of HSIL lesions that we see in the cervix are CK7 positive. And they're CK7 positive because the vast majority arises from the squamocolumnar junction from these reserve cells that are characteristically CK7 positive. So by inference, most HSIL lesions that we see in the cervix are CK7 positive because they arise from that reserve cell population that is characterized by CK7 positivity. So really the clinical value has been into the realm of the low-grade lesions. The low-grade lesions that could be arising from that reserve cell population that are CK7 positive are those more likely to progress to HSIL. In the setting of something that you already know and you are comfortable calling HSIL, I don't really know what would be the value of adding CK7, but I think it's worth waiting to see if studies prove me wrong on that. In the future, they very well may be. Signs of subtle invasion, differential diagnosis will be HSIL or minimal invasive squamous cell carcinoma. Glassy cell carcinoma can be a differential diagnosis of ignorant decidual changes. Yes, I think glassy cell carcinoma can look like decidua, absolutely. But glassy cell carcinoma, number one, will manifest as a mass and will manifest clinically. Decidual change will almost never do that. And on pathology, decidual change will be a very bland population from the cytologic point of view. Glassy cell carcinomas are cytologically atypical. The nuclei are ugly, they're large, they're pleomorphic, and they're going to show invasion into the surrounding wall. And as I said, decidual change is usually incidental and is small, confined to the surface. So that probably will help you in that distinction. Morphological differences between adenoid-basal carcinoma and basaloid, I presume squamous cell carcinoma. Again, number one, adenoid-basal carcinomas are going to look haphazard, but they're not going to show desmoplastic stromal reaction, number one. They won't show perivascular, perineural invasion or lymphovascular space invasion. Number three, the nests are going to be haphazardly distributed, but they're all very nicely round, very well defined. They have smooth convex contours. They're not going to have angulation or fragmentation or quite confluent or complex irregularity that you will see in an invasive process. And they retain that basaloid palisading in the outline of each nest. And that's why we call them basaloid. If you see something that is desmoplastic, that has peripheral paradoxical maturation, or that is too confluent or too irregular in the shape of the nest, is not an adenoid-basal carcinoma. Consider a squamous cell carcinoma. I have last two questions. I think they're in French, so I'm going to do my best to try to read them. Negative HPV by PCR excludes the diagnosis of LSIL. No, not really. Like up to if you're including low and high risk HPV types in your molecular testing, it makes it less likely, but it depends on your test. I think most tests will cover the most common variants of HPV, and low risk variants, including the tests that I've seen available, are 6 and 11 and others, but they don't cover all. So if you're looking at something that morphologically is convincing for LSIL, I will still call it LSIL. Because I don't think the sensitivity for that diagnosis for HPV detection kits is not 100%. So it will make me go back to the slide and make sure that I'm not overdiagnosing something that is benign, right? But if I'm convinced it's an LSIL, I will justify it based on morphology. And I think that's it from the chat. So again, thank you for your attention. In the recording, you will be able to see my email address, and I'll be happy to answer further questions if you have them. Hopefully this was helpful. Have a good day, everybody, and a good end of your 2020.